Oral cancer is one of the most common cancers in India, and to date, still the best treatment for oral cancer is surgery. Early stage tumors probably just require a simple surgery where the part of the tongue or part of the cheek is removed and it's closed primarily, or just use some fat from within the cheek. This is usually combined with removal of some glands in the neck, which are called lymph nodes, which I've done at the same time of the surgery. If the tumor is a little advanced, they may require some skin flaps from either the face or from the neck, either below the chin or from lower down in the neck, to reconstruct that area. This is to help in the mouth opening and also to help in speech as well as in swallow. And the tumors are a little more advanced, then they require more major reconstruction, which probably requires flaps from other parts of the body, either from the chest or from the leg or from the thigh. These are done mainly to help the patient in swallowing as well as in speech, and so that he can lead a better quality of life. All these surgeries are usually combined with the neck dissection, where there are nodes which are in the neck which are removed. This helps us in staging the disease and planning the further treatment. Most patients, once they're diagnosed with oral cancer, they undergo scans which tell us whether the disease is operable. Once the disease is deemed operable, then the surgeon decides as to what extent of surgery and what kind of reconstruction the patient will require. And once the patient is fit for the surgery, as deemed by the anesthesiologist, he is usually admitted 1 day before. And if it's an early stage tumor, after the surgery, he'll probably be there in the ICU or the HDU area just for 1 day monitoring. And he will have a tube in his nose for feeding and a tube in his neck, which is called a drain. The tube in his nose is a Ryle's tube, which is a feeding tube from which the patient starts feeding from the next day. And after 2-3 days, he started feeding by mouth. And once he's able to take well by mouth, the feeding tube is removed. The drain usually comes out in 4 to 5 days, and the patient is discharged by around a week. The patient will usually be able to take liquid and semi-solid diet for around 10-15 days, and gradually will improve his diet. Depending on the stage, patient may require further treatment like radiation, which may affect his diet further, and he can expect maybe to get back to normal diet around 3 months. If the patient requires a major reconstruction, in such situations he will require more tubes, probably a breathing tube in his neck called a tracheostomy, which is there because the patient will have a lot of swelling on his face and will find it difficult to breathe through his normal passage, that is his nose. And the patient will probably have to be in the ICU and the HD area for a little longer. There will also be a dressing and drains from the site where the flap has been removed. He will be in the hospital for around 10 days. And once he's able to take well by mouth, then we can expect the tracheostomy to be removed and the Ryle's tube to be removed. The drains usually, as usual, come out around 4 to 5 days. And like the biopsy which was done before the surgery, whatever tumor has been removed during the surgery is sent for a biopsy again. Based on that report, we will decide whether the patient requires any further treatment like radiation with or without chemotherapy. All patients are explained that there will definitely be some dietary change. If it's early stage, we can definitely expect the patient to get back to normal feeding over the course of time, maybe 2 to 3 months. Whereas if it's a bigger surgery, there may be a long-term change where the patient may have to be on liquid or semi-solid diet. For some patients, it may be lifelong. For some patients, it may be over 6 to 7 months. If adjuvant therapy like radiation or chemotherapy is added, then there will be their added side effects, which also cause a lot of dietary change, where the patient will not be able to usually have any very solid foods and will require liquid foods. There will also be some taste change also, which can be expected. Most tumors, to date, are amenable to surgery, but they definitely have to be in early stage, and more advanced the stage, more the complications and more the long-term side effects. So definitely, if a patient presents in early stage, we can expect a better outcome and they will do better. When the patient has a tracheostomy, The patient will have to breathe through a tube which is there in his neck, but as long as this tube is there, patient will not have his normal speech and will have to either communicate by a written manner or by gestures only. This tube is there to prevent the patient from getting his secretions into his lung and also to help him in his breathing. So once the patient is able to handle his secretions and also able to swallow well by mouth, this tracheostomy tube will be removed. Once the tube is removed, the patient will again be able to speak. This voice may of course be affected to a certain extent depending on how much of the tongue has been removed, but some amount of speech will gradually come back, and the best amount of speech is obviously given when there is a good amount of reconstruction done to the tongue. So tracheostomies are a necessary part, and some patients who have a major reconstruction of the tongue, in such patients the tracheostomy may be kept for a longer time, even maybe during his adjuvant treatment, that is radiation. And once that radiation is complete, gradually the tube may be taken out from his neck. The usual biopsy after the surgery comes at around 2 to 3 weeks time. Based on that report, a multidisciplinary team discussion is held between the radiation oncologist, the pathologist, medical oncologist and the surgeon, where a decision is taken regarding the further treatment. If further treatment like radiation or chemotherapy is required, this is usually instituted around 4 to 6 weeks after the surgery, and it's for a duration of 6 weeks, where 5 days of radiation, and if chemotherapy is required, there is 1 cycle of chemotherapy every week. So that's around 5 to 6 cycles of chemotherapy. So this radiation goes for around 30 fractions of radiation usually. So that's a good duration of 1.5 months. And during this period, the patient is just routinely comes for the radiation for around an hour every day. And if any complications or any requirements are there, he will also be seen by the head and neck team. And post the radiation, the acute side effects usually settle down around a month after the radiation is complete. That's when the first follow-up is kept for both the head and neck team as well as the radiation oncologist. Subsequently, depending on the stage of the disease, further follow-ups are planned. Most follow-ups are done usually monthly for the first 2 years, because the maximum chance of recurrence of oral cancer is within the first 2 years. After 2 years, then it's increased to 2 monthly, 3 monthly, and till the end of 5 years. After 5 years, it's usually a yearly follow-up, because the chance of disease coming back after 5 years is in probably 5 to 6%.